Hello, everyone. My name is Dr. Arjun Patel. I'm currently a second year internal medicine resident at the Rutgers, New Jersey Medical School. Today, I have the privilege to be joined by Dr. Ajay Gupta to discuss his SCRATCH hypertension trial. Thank you so much, Dr. Gupta, for being here today with
Hi.
Fits on the Go.
Thank you, Arjun, and my pleasure here. So, you wanted to know about the SCRATCH-HTN study, right?
Correct.
This study started with the factors that I worked with a renal denervation long time back, and obviously renal denervation is a very good alternative therapy, and it's proven now in a FDA approved therapy, but it's not scalable. It is expensive, and it's in a very specialized centers. So I was thinking about there has to be a alternative therapies which we can offer to vast majority of our patients. 40% of our treated patients do not achieve blood pressure targets, and mainly because they are either drug resistant, they do not tolerate medications, and sometimes they don't like medications or they are not adherent to medications, and we need to cater to their needs. So neuromodulation is one aspect which we can explore further. So this study is a first in human study. So it's not a definitive study, but it's opens the field for further. So what we did was we took patients on 1 to 4 antihypertensive agents. The trial was designed very well in the sense we have taken away lots of learnings from our renal denervation trials. So we did first go a sham control trial, unlike observational studies which people do. So it's a sham control trial. It's double blinded. And we also based our treatments outcomes on the basis of 24 hours ABPM. So our objective was to assess safety, acceptability, and have a efficacy signal based on average daytime blood pressures. So we took 63 patients, randomized 2:1 to either a TAN therapy, which is Trans-Cutaneous Autonomic Neuromodulation, and sham therapy. Now one can argue, how do you do that, sham? And that's a very critical question which I have faced, and with our team we tried to find the solution, because what we did was we are stimulating your tragus, both tragus, and you will feel some kind of perception of that stimuli. It's not pain, but it's some kind of paresthetic things or discomfort at times, or some kind of sensation, and you can't mask it in a sham. So we did our experiments and we realized that sub-perception threshold, when you do not feel it, still may work. So we gave all the patients before randomizations training of using this device, and told them individualized sub-perception threshold. So they will not feel anything. Now the problem with that is the perception levels change over the period of time, but we can't do anything because it will block our blinding. So we did ask them regularly about blinding index. The other thing which we have learned from a renal denervation studies is that people, if they are on a sham arm, or if they will start thinking about newer therapies, because these are uncontrolled hypertensive patients, right? So we have tried to look at this first in human study with all these factors. Now, what did this study found? Our findings based on safety were excellent. This is a device which potentially can be scalable. So it's safe. Almost everyone adhered to the protocol, which was 30 minutes self-stimulation every day for 14 days and then once weekly for 10 weeks. So they adhered. So we've established this device is safe and acceptable. Is it efficacious? Now, the design, when we did this first in human study, you do not do a 300, 400 patient study. You are trying to develop a mechanistic thing. So we did a So our power was limited in the sense we looked at between group difference of 8.4 millimeter, which if in hypertension world with these kind of treated patients, it's very, very optimistic. But we wanted a signal, and a bit within group difference was 5.4 millimeter. That's what we wanted to test. So when we did this study, the results, we have not found between group difference in our cohort of things. However, we have always predefined subgroup analysis and interaction. And we found that those who were at higher blood pressures baseline, they had significantly better improvement, about 12 millimeters with TAN therapy. But that's a small group of people. Now, the question here is, why didn't we find this difference? Is this really a negative trial? Or is there a way forward for this study forward? And we have collected the data, and that's what I'm proud of that it is one of the very well designed first in human study, because we did collect urinary antihypertensive screen for everyone. They have a self-reported medications in addition to the objective criteria that they are taking medication or not. And we collected the blinding index. What we found that in spite of our best efforts, we could not blind fully. So partial unblinding was there. And what it causes is a performance bias with these patients. And the second evidence which we got that was these people were the ones who started taking more medications. So if you are taking more medication in sham arm, and we have a sham effect which was much more than a normal expected drug. So both groups reduce their blood pressures, but sham group reduced much better. And if we plot that in everyone's blood pressure, there were 5 patients out of 20 in sham arm which had a substantial reduction in blood pressures, and which was, we think it's mainly because they have taken new drugs, and that caused effect minimization, and we could not find any results. So the overall this trial was negative. But what it does give is, it clearly shows that in a subgroup it works. It also shows the factors that there is safety, acceptability, and it gives us an explanation why the results were negative. Now, this was further strengthened by our other pre-specified analysis. We asked the people to do a 14 days stimulation every day, and we did after 2 weeks office blood pressure. So we have a office blood pressure that baseline, 2 weeks, 4 weeks, and 3 months. And in that, we found that at 2 weeks, the difference between the two treatment was 5 millimeter, which is what is for the audience. So, which was substantial in the sense 5 millimeter in 14 days on average. Although again, because it's a compliant population, only 34 patients on that one. So we had a low power. We could not find the significant results, but that 5.5 millimeter reduced to 4 something millimeter in 1 month and negligible on 3 months. So when we did our analysis for 24 ABPM and daytime average on baseline and 3 months, our neutral results are explainable that the stimulation frequency which we chose based on our pilot data, where we thought there will be a recruitment of sensory impulses and altered autonomic functions, and that will remain. So resetting the autonomic functions will happen, and then we just need to do maintenance for it. That hypothesis is gone. It shows that we have to continuously, or at least for longer period, do this stimulation. So now we know what is the exact good trial going to be, where you will do everyday stimulation. You probably will try to watch that they are on the same medication, and then we'll know whether this drug works or not. With this trial, we have opened the field for further research, and if this is successful, we have opened the field for one different alternative treatment for hypertension, which is a need of our.
Well, there's a lot to unpack there. Starting with, you mentioned that you saw a more profound benefit for patients who had the higher blood pressures. I know that renal denervation is reserved for those patients who are confirmed resistant hypertension without any secondary causes of hypertension. Do you think that in the future, this vagus nerve stimulation, neuromodulation will be for a similar group of patients with resistant hypertension?
I think obviously there's so many ifs and buts. This is we have to prove that it works.
Yeah.
We expect with the basis of this study that given a better trial design, it's likely that it may work, but we have to prove it. And if it works, then it probably will be for all the patients who have either drug intolerances, which is a huge big group, patients who have drug adherence issues, and including drug resistant patients. So there will be a group of people widespread rather than renal denervation. The reason why renal denervation we have kept it for these kind of specific groups is because of the cost factors, ability to deliver the renal denervations in a very specific group. So that is a different story altogether. Here, this might be applicable all through.
That's awesome to hear. Can you just tell us a little bit about the device and the stimulation? What did the patients feel? Were they reporting any like comfort issues?
So we knew from other studies that they might feel some irritations in the ear or some discomfort. That's what the things are. And that's what we've shown. There was no serious adverse effects in the people who were in an active arm. There was no serious device adverse effects. So there was nothing there. There were only adverse effects noted were mild, which were expected in terms of discomfort and pain sensation if there.
Okay.
But given that, despite that, it was 100% acceptable to patients. So it seems patients are much more willing to get a few minutes of discomfort for their blood pressures and all. And remember, this device, while they're putting this stimulation, they can work, they can watch TV, they can read books and all. So it's just a kind of routine.
Amazing. Thank you very much for tuning in to Fits on the Go.